clinicians. So these are the people that helped me at my residency: Sofia, Ricardo, Ana Mendes, Filipe Campos, and Mário Moreira. These are my students from 2018, and this is the group from 2019. And these are the students from this year. Nowadays, the time I have left to do my own clinical work is virtually non-existent. This project takes up all of my time, and that is the reason why I'm showing you these pictures. The cases you will see here are the result of a joint effort between myself, my team, and my students. Sinus lift is a very popular intervention due to the ease of the surgery, high success rates, and most of all, the favorable anatomy that allows for bone growth to take place in a constrained bone-surrounded cavity without a saliva, without a muscle pull, and without any kind of masticatory strings. Today's presentation can be divided into 6 sections. We will firstly we'll be talking about bleeding, anatomy, arteries, and we will then proceed to bony leads and grafting. We'll also be talking about stability-related clinical aspects. We will discuss membrane perforation repair before we finish with a couple of pathology cases. To address bleeding, to discuss bleeding complications, is to speak of anatomy. We tend to look at the discipline of anatomy as something unchangeable, but this is really far from the truth. In fact, a quick online search will find you dozens of journals and anatomy societies, such as this one that you are seeing on the screen. These are a crucial testimony to the exchange between anatomists and clinicians. And of course, technology advances in diagnostics have changed notions of anatomy throughout medicine, and in turn all clinicians change the way they perform their techniques according to new data on their subject matter. On the clinical side, the results of the applied therapies impel a search for theorems that satisfactorily explain the specific medical activity, those closing sort of a circle of scientific intercooperation. Our first colleague to illustrate and describe the maxillary sinus was Leonardo da Vinci. He did it in 1489. In this drawing you can see he uses his talent to accurately illustrate the anatomical structures of the skull. As a bonus, he would even leave us a dental formula in his typical mirror writing right there. But we would have to wait for 1691 and Nathaniel Highmore to have a detailed representation completely dedicated to the sinus cavity. So hereinafter, this would be referred to as the Highmore antrum. The following years would bring progressive accumulation of anatomical knowledge. Represented here, we see the maxillary artery, superior posterior alveolar artery, and infraorbital artery right there on that area. In 1934, Strong, describing the vascularization of the antrum, would indicate the presence of anastomosis among these vascular structures. These would be present right there. So these vessels would connect between them. And in 1999, Solar would describe the vascularization of the maxillary sinus, taking into account the maxillary sinus lift surgery itself. So that's something that hadn't been done before. And he would describe in detail the presence of 2 important entities that are the internal and external anastomosis of the maxillary sinus. So in detail, we can see here the maxillary artery over there, the superior posterior alveolar artery, the infraorbital artery, and the internal and external anastomosis. The posterior superior alveolar artery has these tributaries that perfuse the posterior and lateral walls. The posterior superior alveolar and infraorbital arteries anastomose in the bony lateral wall on an average of 19 millimeters, this is according to Solar, from the alveolar bone crest. An extraosseous anastomosis would also be formed, so this one over here, would also be formed at 23 millimeters from the bone crest. Here, clearly visible, and this anatomical model is the internal anastomosis, anatomically positioned on the lateral wall of the maxillary sinus, and therefore right in the center of our usual antrostomy. This is an article by Rosano, 100 CBCTs and 15 cadaver heads, and he would conclude that anastomosis will always be present whenever he was dissecting a cadaver. And he found different values from 19 millimeters. So from 19 millimeters of Solar, we go to 11 millimeters here. This, of course, has to do with how you measure these things. If you're taking into account the alveolar plane, well, the alveolar plane can be resorbed, so it's dynamic. So of course, these values will change a lot. And also, if you're taking into account the superior part of the alveolar plane, then you're taking into account the sinus, and of course, the sinus can be pneumatized, and these values are going to change. These antral arteries are only identifiable in CBCT in half of the cases, this according to this article, and this is presumably related to the diameter of the canal, since less than 1 millimeter can be found in 55.3%, 1 to 2 millimeters, 40% of the cases, and 2 to 3 millimeters of diameter of the artery in 4.3%. Now, there are cases where these arteries go through an inner channel, making their detection by CBCT much more complex. So these cases right here can be quite difficult to identify. So it's not hard to identify when they go completely interior, but when they go a little more internally, it's a little bit harder to identify them. But in the event that we are in the presence of a case in which the antral artery has some caliber, has some thickness, then it does not pose a problem identifying it on the CBCT. Here you can see it after it has been traced on the Popular Implant Planning software. If you happen to cut the antral artery, you have bleeding for sure. The amount of it is going to be dependent on the size of the artery itself. Now, you can use any of these methods on the screen to try and stop the bleeding, and eventually you can be successful with every one of them. Time alone can lead to hemostasis. Meanwhile, though, it can be very hard to complete our surgery due to the absence of a clear view. Let's take a look at this case. What you see here is a severed antral artery. So we cut this when performing an osteotomy. To stop this bleeding, we used a probe. So that's what you see on the left on the first slide. A probe entering the antral canal. On the second, in the middle slide, you can observe a controlled bleeding, but the artery has now recessed inside the canal. This is now a not very favorable situation to proceed with our sinus graft, because we have bleeding, we cannot see adequately. So we have decided to gain access to the artery through a small vertical osteotomy distal to the main opening, right there. And on the third slide, here, you can see an attempt to suture this artery. Okay, we're still using the probe, so it's not bleeding, and it gives us time and room to try to suture this. Once we suture the distal portion, the mesial portion of the anastomosis became the escaping route. Here you can see it. It started to bleed from this side. Well, in the center slide, you see me using a plier. This is to hold the artery in place. That's what I'm doing. And I'm proceeding to suture it. In the right side, one can see the enteral artery sutured on its mesial and distal portions, right here and right there. And here you can see the sinus lift procedure that followed. Here's another case. In this case, you can see a lateral window approach where the enteral artery has been identified and dissected. Well, this intraosseous anastomosis is a problem in this case because it is not allowing the complete membrane lift. Therefore, it's limiting the access to the nasal wall. Surgical instruments could easily traumatize this anatomical entity. If severe, this artery could be the source of a permanent bleeding, making it quite impossible to continue the treatment. So we opted to suture this artery on its distal and mesial extremities. And that's what we're trying to do. It's still incomplete design. It still needs some work to be done, particularly on the nasal wall. And it's a fairly big artery. I mean, the patient is not going to die from this if we actually cut this artery, but it'll make it very hard for us to proceed with this sinus lift. We will have bleeding everywhere for sure. Inspect this artery, and if everything is okay with it, we remove the sutures and proceed. If not, we leave the sutures there. Okay, we don't want massive bleeding. Okay, now that we have our vessel ligated, it's time to proceed. You see me placing a collagen membrane, and okay, now some biomaterial, etc. So again, our internal anastomosis is here, a little bit more clearly now. And here we have our final result with the intact artery. Another case yet, this time we can actually visually identify the artery presence on the lateral wall. So we created an osteotomy, avoiding this artery. And we left a sort of bony bridge on top of this anastomosis, and we continued with our sinus. We can see our membrane lifted here. Yeah, and we filled this with biomaterials. This case is finalized with a collagen membrane and some tags. But nowadays, it is of course very easy to identify and avoid these structures. On the video, you can see a bone level guide that acts not only as a good way for implant placement, but also it limits the osteotomy, the sinusal osteotomy, the entrance osteotomy. There is a tooth supported portion on purple, and this is done by means of an intraoral scanner. There is a bone level guide that is the actually osteotomy window, and the connection between both these, and these, that doubles as the implant guide. And you can see also the enteral artery in yellow, and also a big red mass that is actually the sinus. So we work around the artery whenever its size seems a threat to our sinus lift, which is actually a rare event, or we still perform a sinus lift anyway, knowing precisely where we are and what we can find. Let's talk about lids, about bony lids. This is a classic article from the Tarno team from New York. This split mouth with bilateral sinuses, 12 patients. On one side, the sinuses were covered with PTFE, and on the other side, it was not covered, they were not covered with anything. 12 months later, samples were removed from the side window, and the mean percentage of bone formation was 25% with membrane and 11.9% without a membrane. And so it seems to make no difference whether a resorbable or non-resorbable membrane is used to cover the defect area, according to other articles. The use of a membrane seemed to increase the augmented volume as compared to when no membrane was used. And the use of a membrane seemed to prevent soft tissue invagination, providing an occluding surface, granting an undisturbed intersinusal graft maturation. But now take a look at this. This is a meta-analysis by Lopez de Lamo that summarizes the current scientific evidence regarding the use of membranes in the elevation of the maxillary sinus, specifically in the formation of new bone. So this study shows no differences in the formation of new bone. Average vital bone is 33.07% for the non-membrane sites and 32.36% for the membrane group. Now, how can this be? Well, in previous studies, it is not uncommon to find a lack of information regarding key aspects. It is of the uttermost importance the following: the size of the window, buccopalatal dimensions of the sinus cavity, remaining alveolar ridge height, location and depth of the harvested bone, core biopsy samples. They were often taken from the crestal aspect of the ridge. Not surprisingly, it was shown in a preclinical study that the greatest amount of bone formation takes place in the lateral areas of the sinus, while the least bone formation, it's noted, inside the sinus, close to the sinus membrane. But also horizontal dimensions of the lateral window and systemic conditions. So we're lacking all this information, so it makes it very hard to compare grafted sites. And so these authors would conclude what is now obvious for many clinicians. Vital bone formation after sinus augmentation, I'm reading it, using the lateral window approach is not influenced by the use of buried membranes over the window, the grafting material, or the healing time. So none of this seems to be particularly important. Therefore, it is assumed that the most relevant factor for the maturation of the graft material is the recipient site, whereas the choice of biomaterial and membrane remain secondary factors. So we are back to the initial observation that the sinus cavity is a very unique anatomical location, and this anatomy seems to be the most important factor when one considers grafting it. And if there are any reasons to place a collagen membrane to cover a sinus osteotomy nowadays, for me, is not to increase the formation of new vital bone, but to prevent the graft from being expelled and to ensure its stability. Let's say this case where the implant biomaterial has been dislodged into a tunnel in the anterior region. Okay. See, this came from the sinus. We performed a regular sinus. And well, luckily, enough biomaterial remained inside the sinus still allow us to place an implant, but it's still a fairly short implant. It's an 8-millimeter implant. But notice the amount of biomaterial that was actually expelled due to the pressure inside the sinus and the fact that we have no barrier whatsoever that could contain this. Here again, completely obvious, pretty distant from the sinus side. Well, this case where we can see an alveolar process in need of a graft, we removed the bony lid and we screwed it on the crestal alveolar portion. And we did use a collagen membrane here, but it was still not effective containing this material inside the sinus. So even when using collagen membranes, sometimes we have those situations. So this is a very interesting article. This is an histological study on bone formation between replaceable bony window barriers and collagen barriers grafted over bone in sinus augmentation. Well, in this experiment, this is from Son and Kim. In this experiment, on the calvaria of rabbits, we have on one side a replaceable bony lid. This is what you see here with a screw. And on the other side, you'll see a collagen membrane. Now, what these authors found was new bone formation, faster and denser in the experimental group using sinus membrane elevation alone and the replaceable bony window. So no biomaterial, just a replaceable bony window. Then in the control group, which was using bone graft and the collagen membrane, specifically BioOS, I believe. So the replaceable bony lid, bony window has osteoinductive potential and accelerates new bone formation during the early healing period compared with that of the collagen membrane over the bone graft in the lateral window. This is another study by Kim and Son in humans, this time 103 maxillary sinus with replaced bony lids. More mature bone was observed along the floor of the replaceable bony window than at the center of the graft side. So this study demonstrates that the replaceable bony window acts as an osteoinductive homologous barrier. Same histological pattern we can find in Tawil in 2018. So we replaced our sinus bony lids, we put them back on their original position, and we do it by using osteosynthesis plates and screws. We do this routinely, and we do this using many shapes and configurations, as you can see. And well, the benefits of this are you are not using any more collagen membrane of animal origin. You're using autologous bone. It is not resorbable, this bone, because it's so cortical. It will help in vital bone formation, as you've seen. And this effectively contains biomaterial because it's such a strong barrier and can later possibly be used even as a graft material or as a vascular source for a subsequent graft. Now, on a technical note, these are the tips that I use. Particularly, I use the first one, the saw tip. I don't like so much to use these ball tips because of the equator. Whenever I pass the equator, such as this image, whenever I pass the equator, I tend to perforate instead of performing a fine osteotomy. And when I'm using a saw, this doesn't happen all the time because there's always a certain portion of the saw that actually is placed against the bone, and the other portion of the saw is actually performing this osteotomy. And I also take care to do it angled so that it can be repositioned a little bit better. Regarding the window dimensions, we basically try to stay away from anything with a name. We use a 2mm safety margin, and we use a smaller window for single implant cases and a larger window for multiple implants. It's something I picked up from Tiziano Testori's team and Matteo Invernizzi. We also tend to use smaller instruments for smaller windows, and we have sets of larger instruments for the larger antrostomies, of course. So this is a normal result that we obtain whenever we reopen a case, whenever we reopen a repositioned bony lid. This is is an integrated, immovable window. This doesn't move at all. We don't have the invagination of connective tissue. But you see the areas where the gap was not completed with bone scraping, and I mean over there, you can see some soft tissue infiltration there. Yeah, particularly if you don't place any scrapes.
You can love it, you can leave it. Just say nothing without it.
This is an excellent article by Zerbo, reminding us that the majority of the osteocytes of a monocortical bone graft, they don't survive grafting at all. So the results indicate that the new vital bone is progressively remodeled into vital bone 7 months after grafting. So what does that mean? It means that once the bony lead is performed, no cells actually survive the procedure. And if we take a look at the graphic, we can see that at 3 months, we have patients, they have very, very different results. Some of them will have completely revascularized bony windows, and some will need more time. When we have more time to heal, then we have more vital bone. Another interesting use for a bony window can be illustrated in this case. Now, this is something that I picked up from a Japanese author, Kaneko. It's very interesting. And in this case, we delimited the sinus according to our CBCT. So we traced the rectangle, we removed the sinus window, and then we used some screws and plates in order to both secure it in place, but also to maintain the sinusal membrane elevated. As you can see here, lots of screws and plates, I know. Yeah, but here you can see it in place. So what we have here is those two yellow screws, and here you can see some scraped bone. Okay, here you can see it, some scraped bone. Just making sure that we don't have soft tissue invagination, or we keep it to a minimum on that side. And these two yellow screws are going to act as a tent for the membrane, and we graft this side with nothing at all. Okay, there you can see we actually have a sinus on the other side, a more traditional approach to the sinus. Yeah. Now, this is another case when we finally manage to execute our sinus lift. Our goal should be to fill a space and maintain it. Stability along with vascularity is a condition without which there is no bone regeneration. Now, you see this case, the biomaterial is basically spread out everywhere. In reality, the biggest problem in this case was the fact that the membrane was elevated to the distal too much, so that we didn't have to put a lot of pressure on just one point. Okay, so we went further and further to the distal so that we could adequately elevate this sinus, so that we were sure that we had access to the nasal wall. And
there was a time when my world was filled with darkness, darkness, darkness. Then I stopped dreaming, now I'm supposed to fill it up with something, something, something. In your eyes I see the eye.
An interesting way to avoid this case is doing this, is to place a big collagen plug distal to the graft side, to act as a barricade the biomaterial. So this is a little tip that can be really, really helpful. Really, really helpful. Let's talk about grafting. This is a very famous, very well-known article written by Curie about bone grafts harvested from the retromolar area. 3,874 harvesting procedures, and the conclusion being that relatively large volumes of bone block graft can be retrieved on the mandible with a low complication rate. Curie proposed the harvesting of bone from the retromolar area, as you well know, and from this area highlighted. And he would take advantage of the fact that the cortical bone is very hard to penetrate by blood vessels and that the medullary bone is vascularized very rapidly. And he proposed the manipulation of the graft obtained by splitting and scraping the cortical bone, thus obtaining 2 thin sheets of bone and also a generous amount of scrape bone, which is what you see on the picture. Now, you would dispose these cortical blades, these thin cortical blades, and we would then proceed to screw them to the alveolar process on a specific way in order for them to contain the scraped bone on its interior. That's the concept, to contain the graft. Here's the typical configuration of this in the mandible. Here's the clinical example 4 months later. Here's another example. See a very, very thin 1 millimeter ridge, and we went from 1 millimeter to a very interesting result. But these things have this concept has its roots on epicoectomies with the reposition of episectomy windows. So this concept is, of course, by no means exclusive to the retromolar region, but can also be applied anywhere in the maxilla or mandible. Here's an example of this concept being applied outside of the retromolar area. This patient needed both her molars removed because they were impacted in such a way that it would be very challenging to do anything else. But because we didn't want to end with a lot of bone removed from the molar area, we decided to execute, because we wanted to place an implant later on, we decided to execute a bony lid, thus limiting the bone removal to a minimum. And so we removed the impact teeth, preserving the bony lid, as seen on the right. And we also scraped it in order to collect a large amount of easy to vascularize bone. And then proceeded to reconstruct this area, securing the cortical shell with some screws. Here you can see the final result. Let's take a look at yet another case. This is an atrophic ridge, a very atrophic ridge. Well, a fairly atrophic ridge. And we need to perform some kind of augmentation here for sure. As this guide clearly shows, there is insufficient width of bone for implant placement. So we collect the antrostomy bony lid. It's a very thin cortical piece of bone, so we can't really scrape it, but it will revascularize beautifully. So we actually decided not to graft the sinus, but to tilt our implants there on the distal. We also did some bone expansion. These are DO expanders. And ended up with a reconstructed ridge after collecting bone from the tuberosity. Here's another interesting case. We have a post-extractional case. We can see that we will be left with not so big of a ridge. So we will be grafting this sinus. We will also be extracting teeth number 28. Patient was complaining of pain in that area. Here we can see the anterior artery on our way. And for this case, we went with an unusual approach. We decided to approach the sinus palatally. So you can see a vertical incision on the canine area, an area where the dimension of the palatal artery is diminished And we access the sinus through a rectangle made by piezo. We extracted the lead. As you can probably see, the palatal bone in this case, in this area, is thick, much thicker than the bone obtained from the vestibular side in the previous example. So this is what we obtained. And this is the vestibular view. So we need some kind of barrier there. We also extracted tooth number 28, and we actually grinded it, and etc. We splitted the harvested bone. This is osteosynthesis screw going through it. This is the remaining half. And so we created a contained defect here. This is beta TCP, 3-calcium phosphate. So this is scraped bone and the dentin graft. And again, the palatal view now with our sinus performed, with our graft in place. We now replace our bony lid. No screws needed on the palate. The thick palatal mucosa will keep it immobile, so no need to complicate. And this is the typical look that you obtain after grafting. And here you have the radiographic view. It's ready to place the implant. Well, let's talk a little bit about stability. For aesthetic reasons or space reasons, both determined by the discipline of prosthodontics, we sometimes have to perform reductions in our alveolar process. Now, different levels of reduction, however, will have a different impact in our surgery. As in many other situations in our practice, the most dangerous scenario is not the most extreme, but the intermediate one, because it masks the danger that arises from these situations. So in the illustration, the reduction line A completely exposes the maxillary sinus, so implants will hardly be placed in this situation. And line C represents a moderate situation, moderate reduction, and therefore no complications are anticipated. Now, in the line B, things can be a little bit tricky. So the reductions that lead to implant placement in situations with little stability often result in situations like this, with migration of the implants to the maxillary sinus. Or this one, in which an implant migrated to the nose, very, very close to our patient's throat, between swallowing and aspiration. Now, this osteotomy of this case was performed in the 24-25 region. It is just that this patient has an unusually large size of the nose, which in the region of the second premolar occupies the space normally where the maxillary sinus would be. This is manner, and in 55 cases of migration of implants into the maxillary sinus, he reported the incidence of oral-enteral communication in 46 cases. So the first step on a situation like this is got to be to negotiate with the patient and your prosthodontist. Maybe we can achieve an aesthetic or mechanical compromise. Maybe you can't use acrylics. Maybe you need to use zirconia. Maybe you need a not so steep reduction of the alveolar plane. Maybe this is the simplest solution for these cases. But other cases, of course, will exist in which this solution is just not acceptable. So what I like to do in these cases is to flatten the alveolar process up to the anterior wall of the maxillary sinus, up to here. And I would use for that a microsaw, and that will allow me to collect bone that is removed. Now, in the posterior sector, to minimize the probability of perforation of the maxillary sinus membrane, I would use a rongure or a large burr. So you don't wanna be anywhere near the sinusal membrane with a micro saw. That is pretty obvious. Then we will find our maxillary sinus exposed. He is visible here on both quadrants. Okay, quite visible. In these situations, we can consider complex surgeries for sure, zygomatic implants, segmental osteotomy, but I try to keep it as simple as possible, and one of the options is to use the harvested bone to perform a maxillary sinus. On the apical portion, you would place autogenous and biomaterial, and on the crestal bone, on the crestal area, a block secured by screws, or simply 50-50 autogenous and xenograft and collagen membrane. I don't want to do the graft before I have to do a reduction because I don't have autogenous bone that way. If we go this route on the left of the chart, over here, graft before, we will have to wait at least 9 months for xeno to integrate. And then we'll place our implant and wait 3 months more. 9 months, because we're talking about absolutely pneumatized sinus, no residual bone height at all. So it makes it very hard for this biomaterial to turn into a full mature graft. So if I do bone reduction and graft on the same day, I will have autologous, but without residual bone, we will always have to wait a long time until we have initial stability for our implant. So ideally, we should be able to do the reduction, the graft, and the implant in the same day, for which it is necessary to guarantee the stability, of course, of our implant in an area where we just don't have any bone at all. So how can one stabilize an implant here? Well, if the bone left by the reduction is not enough to stabilize an implant immediately, one of the alternatives may be, within reasonable limits, to increase the size of the implants. Okay, it may be just as simple as that. However, there are maxillary sinus, of course, they are so wide that this solution just may not be enough. But whenever this is possible, please go ahead and do this. It will be for sure, the simplest solution that one can find. Now, in these situations that you can find a suitable wide implant, in these situations, it may be an option to place our implant squeezed against the graft to stabilize itself, to place an implant through a graft, or to use something external to stabilize the implants. Pretty much like this. This is a DUSCM implant. I told you!
Get on it. Go down.
With this device, you can place your implant, leave it immobile, and proceed with your treatment. Let's take a look at a clinical application for this. In this case, we perform the lateral sinusal window. You can see a little artery there. And the residual bone height for this case is absolutely minimal. And what you can see here is that the implant insertion on such a borderline crest led to fracture of the alveolar process. So we have no stability of this case. The implant is swimming in the sinus, and the solution we found was this. The replaceable bony lid we already discussed. The green plate is attached to the zygomatic process by 1.3 screws, and it's connected to implant by a angled multi-unit screw, which are the ones I found with the smallest size. So this allowed me to immediately placed this implant on a sinus that offered me zero stability and shortened my overall treatment time considerably. Actually, I have a few of these cases, and this works out very, very well. Never had any success with this, to be completely honest.
Drugs and girls.
Here's a video.
Show me some love, my love. Last time I checked, you love my love. Place nothing above my love. If you leave, come back like above your butts. No ifs, ands, or buts is sufficient, but I still wanna fill you up. Just when you thought enough was enough, I'm a kid in a museum and I just wanna touch every part of your body. Tie you up and get naughty.
Hold me up in this potty, high power, money showers. All the ladies wanna kick it with Mr. Miyagi. Pull up, bring it back, come rewind.
Hey.
I wanna touch up and down your spine. A perfect 10 living on cloud 9.
Here's another case, Kelly syndrome on this case. It's an edentulous maxilla opposing a natural dentate mandible, loss of all the bone on the anterior part of the maxilla, extrusion of mandibular teeth, bulky soft tissue, large tuberosities. And we perform a number 4 on the lower. Some SCM implants there.
And I know the money don't really make me whole. The magazine covers drenched in gold. The dreams of Granny and mansion and happy. The little things I need to save my soul. And I know the money don't really make me whole. The magazine covers drenched in gold. The dreams of Granny and mansion and happy. The little things I need to save my soul. Who am I, gypsy rap? Gypsy need her dollar back and all of that. My devil's only closer when I call him back. Lick her in the limelight, lick her in the limelight with fine wine and ecstasy. You can have the rest of me. Basket case, silhouette, cigarette, internet. Check my Twitter page for something holier than Black Death. Who am I, gypsy black? The vacancy of Hallelujah. Me hollow in my interviews. Me only wearing tennis shoes to clubs with dress codes. Cause fuck they clubs. Everything is everything. Me no name. Me niggas doing cocaine. Me missing brother Mike like something heavy. Me heart just wasn't ready. I wish I was a kid again. When the sun is going down, when the dark is out to stay, I picture your smile like it was yesterday. When the sun is going down, when the dark is out to stay, I picture your smile like it was yesterday. When I remember memories don't last forever. When I deny my empty with an open letter, who gon' remember me? My satellite, my empathy. The wheels be chrome, spiffy. The Lord with me. My halo said goodbye and the floor hit me. Velvet lining in a pine box. My granny filled the time slot. Don't grow up too soon. Don't blow the candles out. Don't let them cops get you. My granny almost sparrow. I can see the wings. The choir sings and not a thing. La da 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 da. Only he can save my soul. And I know the money don't really make me whole. The magazine covers drenched in gold. The dreams of...
Let's talk a little bit about membranes. We all know the respiratory epithelium. Up here we have the cilia. Over there. These are responsible for directing mucus to the ostium. Underneath we have goblet cells producing mucus. Goblet cells. Basal cells. Connective tissue. Underneath we have the periosteum. It's not represented here, but we have periosteum underneath. The thickness of a membrane is considered normal if less than 2 millimeters. The thickness of the membrane does not vary with sex, does not vary with the season. It actually varies with age. Older people have Schneiderian membranes a little bit larger, and this is speculated to be due to cicatricial tissue, some scar tissue. And we sometimes hear that smokers have a thicker membrane, but more precisely, we can say that there is a goblet cell hypoplasia, and we may have increased inflammation as well. So, in fact, take a look at this study that aims to compare membrane thicknesses and perforation rates. The highest perforation rates exist at the extremes, when they are very thin and when they are very thick. When they are very thin, it's because, they're not so resistant. And when they are very thick, they can be thick at the expense of inflammation of the cellular component, making them more fragile. So how do we know what kind of membrane we're going to work on? Well, a good way is just take a look at it and examine the color. If you're working on a whitish membrane, there's a good chance you're working on a very, very easy, favorable, thick membrane. And if you're working on a very dark membrane, there's a very good chance that you're working on the thin membrane, and it's dark. It's darker because you can actually see the sinus interior. Well, and depending on the thickness, we can establish several strategies to repair any perforation that might occur. Now, there are a lot of examples on the bibliography of how you can repair a perforation, ranging from attempts to use cyanoacrylate, to Bichat ball, sutures, all kinds of sutures, collagen membranes. This is from Picos. A very nice pseudocyst on this article. This is from Tiziano Testori, just a wonderful suture example from Tiziano. Fibrin glue, etc. A lot of ways to do it. So what we do in our clinical practice is we suture depending on the thickness on the membrane and the position of the perforation. We're not going to suture very, very, very thin membranes. We try not to do that. That only worsens the problem. If you have a small perforation, we continue with the sinus lift, have our membrane folded against itself, and that alone solves the situation most of the time. If you give it enough time, the coagulum will organize around it. Now, larger perforations, we'll need a suture or a collagen membrane, depending on the thickness of the membrane. So if it's very thin, I would rather go for a collagen membrane, of course. And when we have perforations that are larger than 10 millimeters, then our policy is, our experience is just, it's probably wiser to abort the procedure. We have mixed results when trying to repair these situations, and when things didn't go so well, they went really bad. So it really, we just aborted, and then we re-enter. But we re-enter three weeks later, and that's it. And 3 weeks later, well, I'll show you in a moment how we do it. First, let me show you a typical. This is a very nice membrane, a very strong membrane. So it's very easy to suture. It is this kind of membrane that you should attempt to suture. A lot of things would work here. I like to suture, but just to show you what's a very nice membrane. It's a very thick membrane. Okay, a very opaque membrane. So this is the kind of membrane that you should try in the attempt to do these things. And this is a popular article by Processos and Losadas, the Loma Linda pouch. Very interesting technique to repair very large perforation. But again, this is something that I obtain mixed results with. So I rather just abort. And then what I do is I re-enter 3 weeks later after my perforation, but I re-enter on the split thickness matter. What I do is I leave some of the periosteum of my flap attached to the osteotomy side, attached to the membrane actually. So this will act as a cushion. And this will make our procedure very much easier. You can see all of this area here is actually with some periosteum of the flap. attached to it. A little bit clearer now. And here you can find a really nasty result. Nasty. We had some complications, some very, it's a complicated case. It came to us. We had implant loss here, oral alternate communication, everything. A lot of complications on this case. But yeah, we could. We also have membrane perforation when trying to perform a sinus lift here. But this is the way to deal with these cases. And as you can see, I then like to use the collagen plug that will contain my graft on the disc. So on one hand, I really like to elevate the membrane from all sides on my sinus, but then I end up with a too large of a sinus to graft, really. So I like to contain my graft with these collagen plugs, and then I would cover this site with the collagen membrane. Yeah, just to try and maintain the graft inside the sinus. Here's the Crestal approach. You can see a little perforation there. A little bit clearer now. We adapted the collagen membrane, pushed it through the osteotomy hole, covering this very small perforation. And we proceeded with the graft. But we are very aware that the majority of transcrestal perforations go undetected. Some authors would report no less than 13% when we use interoperably endoscopy. So, implants protruding into the sinus 2 to 3 millimeters into the antrum will heal with complete regeneration of the membrane. Take a look at this article by Jung on dogs. In this article, if an implant protrudes 2 millimeters into the sinus, the membrane completely covers the implant. But if an implant of 4 millimeters is placed, or 8 millimeters, then the implant is exposed to the sinusal cavity. This is new in 2013, intentionally perforating the membrane using a 2 millimeter twist drill at implant placement. And all of the 63 used implants would protrude up to 3 millimeters. So you would have a little bit of epistaxis, but a 98, by a little bit, I mean 12%, and 98.4 success at 1 year post-restoration. So if we perforate the membrane crestally, if you're sure that you perforated, and that's the biggest problem with the crestal approach, then we would use an implant that is 2 to 3 millimeters longer than our residual bone height. Now, this has to allow us to place an implant with 4 millimeters and at least 8 millimeters in height, with, of course, enough torque. And if we can't do this, then we abandon and return in a couple of months. We don't use any particulate graft if we ruptured the membranes, if we perforated. And, we don't use it because stability and vascularization may be compromised. So we only place collagen. All right, before we finish, it's time to look at one case with pathology. We have a lot of pathologies that can happen in the sinus: sinusitis, polyps, antral pseudocysts, infections, mucocells, etc. Some of these clinical situations result in contraindications for the procedure. Some of them are temporary, some of them are reversible, and some of them are irreversible. Now, irreversible situations may be linked to some serious pathology. I'd like to request your attention to this article. This is a tremendous article by Friedland. It's a guide to recognizing maxillary sinus pathology. This author will also provide guidelines for subsequent action based on these findings. I can't recommend this article enough. We will be focusing on this today. This is a pseudocyst, a drawing of a pseudocyst. Enteral pseudocysts are benign, dome-shaped entities that result from obstruction of the ducts of the glands that produce mucus. They are relevant when they reach such a large volume that they can compromise the patency of the ostium. Now, here's a specimen that we found when performing a zygomatic implant. This is how it looks. And let's take a look at the case. As you can see, an antral pseudocyst is present there on the first quadrant. And we have an absence of bone on the premolar region. We perform our regular bony lid. Show you a video now. Yeah, we used our piezo, our saw tip, make a rectangle. We're gonna use a Lucas curette to detach our bony lid window. We're gonna use a 15C blade to make a perforation on the Schneiderian membrane to gain access to the pseudocyst. There are several ways to do this. This I picked up from Radoslaw Jadar. You can do this on more traditional style, I guess, by Chiapasco. We are aspirating the content of the pseudocyst, all the mucus, so the size becomes much smaller, so that we can actually retrieve it, occupying the least space possible. We're gonna now suture it. Not a great membrane to suture. Actually, you can see little rupture over there on the top. Oh, I can show you. Okay, this is not working properly for some reason. Oh, something is wrong with my pointer. I need to show it again. I'm sorry. Something was wrong with my pointer. Where were we? Right there, I believe. So over there, not so great looking. We will have to fold this membrane against itself. Otherwise, we can have problems there. I'm not saying we would have, but we can have problems. So we're gonna add some more suturing. We're gonna add a little hole on the lateral wall. Yeah, like that. And now we're gonna suture it to that hole. Now I'm using a collagen membrane. I'm going to use the bony lid to reconstruct the site on tooth number 14. Retrieving some bone from the tuberosity. Okay, this is how it looks. See, nice filled sinus and the reconstructed area. This 3 months later or something like that. This is the final result. So, well, thank you so much for attending. I will try to answer some questions now. So if you want to answer, if you want to ask some questions, please do it now. Okay, which collagen plugs do you use? Color Plug by Resorba. Let's see. Some complications with sound, I noticed. Yeah, we were testing this before, but unfortunately we couldn't. That's the best we could do. Take out the bone block from the lateral wall. Well, I think I showed that. Yeah, with the piezo tip. A lot of complaints about the music. I'm sorry, man. What total time needed from grafting till prosthesis deliver in a deformed maxilla? Well, it really depends on a lot of things. It will depend on the residual bone height. That plays a big role, meaning how much bone was there before. The quality of bone, of course, you just said before, so we'll have to wait a little bit more. The size of the sinus, the buccolingual size of the sinus is a big factor, okay? Not all sinuses are equal, so you will have to wait a lot more on a large sinus and on the biomaterial as well. If you're going to use autogenous bone, you can expect to wait a little bit less. If you're going to use only biomaterial, then I would advise you to wait a little bit longer. So it's a combination of all these things. There is not a recipe, but I tend to use autogenous bone for most of my cases, even if just a few scrapes. And in most of my cases, 6 months, most of them. Some cases, really large sinuses, really large. I mean, 1 millimeter, a large sinus, and I'm using mostly biomaterial. Then I would advise 9 months or more, actually. Okay, guys. There's my email on the image. Anything that you shall need, you can contact me through social media or through email or whatever. Okay. Thank you for attending. Thank you very, very much. Bye-bye.